All right. Well, welcome everybody. This is again, this is Jeff Bowles with PMI. They're hosting the technical webinar series, and we are honored to have Laura McGladrey here today. And since we're getting a little bit started late, Laura, I'm just going to turn it over to you. If you could just do kind of a brief introduction about yourself, and then kind of a brief summary of your what your presentation is about. That'd be great.
Sure. Hi, everybody. Laura McGladrey. I'm a psychiatric and family nurse practitioner with a background in, I would say, emergency medicine for a lot of years, humanitarian wilderness medicine, and austere medicine. I work at the university with law enforcement and fire around the topic of traumatic stress mitigation, basically. So I interface, I think, with the wilderness context with a lot of years as a wilderness medicine instructor. I've helped to bring this into our curriculum at NOLS. Todd Schimmelfennig, the curriculum director at NOLS Wilderness Medicine, has really taken the lead on bringing this into wilderness medicine education. So I have the pleasure to work with a lot of teams in rescue, both structural fire and law enforcement, but also ski patrol and search and rescue, both in and out of the national parks. So this is probably a little bit of context for what we're talking about. What was the part 2 question? I think you might have asked for some.
I'm sorry. Yeah, just a brief summary of the presentation.
Sure. So, yeah, today I thought we would spend some time honing in on psychological first aid. And this is a concept we have seen, and I'll do my best to let you know why I think it's important to both emergency response and rescue. But I thought we could spend some more time actually on the tools in psychological first aid. And psychological first aid in a nutshell is really just the mitigation of stress injury types, kind of injuries that occur in a state of overwhelming stress or exposure to traumatic stress. And we see this really day in and day out on rescue. We'll talk more about that.
Okay, thank you. And so just before we get started on the actual presentation, I'm going to go over a few housekeeping items. All attendees will be muted during the entire webinar. We will have time at the end of the presentation to answer any questions you may have. For questions related to the presentation topic, you may type in and send questions at any time during the webinar using the questions function on the dashboard. You may use the chat function, which is separate from the questions function, for any other comments you may have. The webinar will last approximately about 1 hour, is that correct?
That's right.
Okay, great, 1 hour. And again, when we end the webinar, we will take questions at the end. If you're having trouble with your sound, you may switch to and from your computer to a phone, or the reverse as needed. So, all right, well, let's go ahead and get started. And Laura, take it away.
Sure. So I would say that I became curious about this phenomenon, I would say probably 7 or 8 years ago, and I was noticing a pattern a lot in wilderness medicine education and candidly in other arenas too, like just wilderness response and working again in more of the higher reliability teams. What I kept seeing is that we would spend, hopefully folks have a picture in front of them, you know, for years and years this was such a familiar scenario, and I'm sure it is for folks looking at it. We'd think about how to improvise litters and splints and create hypothermia wraps and how to safely evacuate and haul this person off the side of a mountain. And I think we're very good in the wilderness currently at getting folks stabilized, recognition of what injuries they have, and moving them forward. So this is a patient that we could kind of speculate may have fallen from something, has a closed head, injury, maybe a pelvic fracture or a lower extremity fracture. And what will likely happen here is that we will package them, stabilize them, either short haul them or walk them down or something, and they'll go on to definitive care. What became interesting for me is that almost always in this situation, just off screen one way or the other, there's another party, someone who was skiing with them, who was belaying them, that witnessed this happening. And we will often come on scene, survey the scene, find out we have 2 people involved, check the one, they have no injuries, and then focus all of our attention on the 2. So if you could look at the person who's off screen, this might be familiar, and if we had a chance to talk about it, all of us together, people might describe that person as angry. They might be pacing. They might be asking the rescuers, why did it take so long for you to get here? Why aren't you doing this? They might be trying to help. And all up in our kitchen, they may be just sitting there with their head in their hands. They may have a 1,000-mile stare. And what tends to happen is all the efforts go into caring for the physically injured person. The person who's with them will often be, however they get down, we walk them down, we wrap down to wherever their car is, or their people are waiting, and we make sure they're warm and maybe fed, and we put them in a car and they drive away. Well, what I would see, or they would rendezvous at the hospital, whatever, what I would see is the person physically injured who got evacuated would end up going to the hospital. There'd be a bunch of people there to support them. There'd be meals, there'd be GoFundMe, there'd be all sorts of support and all manner of support. And they might go through the ICU, the step down, back out to physical therapy, but they'd be skiing next winter. And what I found would happen time again, and I've seen this so much in rescue, if you follow the person who was, again, belaying them, skiing with them, was on the expedition with them when it happened, they will often go home, not be able to concentrate at work, maybe not feel included in the rescue efforts, especially if they made a call, right, that high avalanche conditions, we shouldn't have gone, or they were belaying, or somehow feel responsible. That person, if you watch their progression, tends to go something like stops coming to the rescue meeting or stops coming and out on hut trips. You might follow them through the spring. They break up with their girlfriend, they sell their skis, and they take up mountain biking and move somewhere else. And honestly, it was the American Alpine Club a few years ago that called and said, hey, what is this thing? Because we keep watching it happen. Our talented climbers who don't want to climb anymore. They don't want to lead trips anymore. They don't want to, whatever the XYZ is anymore. And I think that really led to the curiosity. Are both people injured on this scene? Is party A, who's laying here in the sleeping bag, and party B, who watched it happen, both injured? And the resounding answer is yes. So the new nomenclature around this injury type in rescue and climbing and outdoor pursuits is stress injury. We actually have adopted that from the military context. Here's a couple things about stress injury. They occur on a continuum, which we'll just touch base on briefly, with early and late changing vital signs. So what that means is that for me in my clinical life, I treat a lot of post-traumatic stress disorder, but to get that diagnosis, I actually have to demonstrate that you've lost function somehow, that is impacting your life in such a negative way that you're seeking care. So post-traumatic stress disorder, although incredibly real and very disruptive to living the joyful life we're meant to live, is only the tip of the iceberg for stress injury formation. Underneath that, there's all manner of ways that we can be stress impacted. And up until now, I'm not sure we've had a language to say, I don't think I have post-traumatic stress disorder, but I sure as heck don't live life in the same way after my big climbing fall, or after that happened, or after I watched that happen to someone I care about. So this is a discussion we've had in wilderness medicine. In other areas, if we're talking about shock or head injury, both will have early or mild vital signs, and then we'll actually see the severe. So in early compensated shock, we might see that folks' blood pressure is maintaining really well. Yes, their heart rate and respiration rate is elevated, but there's still room to mitigate. Maybe we need to stop the bleeding. Maybe we need to add volume. And that's really what I'm advocating we think about in rescue along the lines of stress injury formation. I think in this conversation as well, we won't spend too much time on it, is the understanding that stress injuries are actually physical injury types. So if we're spending heroic time and energy to rappel down to someone, stabilize them, and get them out of the backcountry to mitigate their comminuted fractured leg so that they can go to surgery, do well on it, and get back out there climbing, there's no reason that we don't have a toolkit to mitigate these injury types, because they actually fall categorically under physical injuries. And here's the how of that. What happens for us is that our first fight or flight response that we're meant to, let's say we're driving on the highway, the road is icy, we lose traction and we start to slide. In that moment, we will have this immediate response where we, there's a rush of catecholamines, there's a rush of like heart rate goes up, respiratory rate goes up, pupils are dialed. We can feel that flood of tension in our bodies getting ready for something. In that moment, if that resolves itself because we get traction again and keep driving, then we probably won't remember it again. We'll come back to this later. But if we end up being in a sustained state of surviving for a long time, let's say right now in California with a wildland fire and Cal Fire, and they don't know where the winds are going to go next, or they're overwhelmed and they have to just keep going through exhaustion and fatigue. We have this great mechanism built in for that, right, which is cortisol secretion. So it's meant to sustain us. If it's a famine, then it's supposed to store up fat for later, keep us awake, drive up our blood pressure, put bone density off until later. But candidly, many of us stay stuck in this pattern because there was never an all clear signal after an event, and we're still secreting cortisol waiting for the next thing to happen. And this is kind of the list of things that we see in occupational, even in unpaid professionals in rescue, when this is the arc of a career where you stay in the sustained state for a long time. So the good news, though, is that stress injuries can be supported when they're recognized. That's why we have a language around this now. I'll briefly show you the stress continuum that we're using in a lot of rescue. And then finally, they're more likely to occur in a state of stress. And this probably gets at mitigation. This is a quick look at the Combat and Operational Stress First Aid Continuum, first adopted by the U.S. Marine Corps. And the idea here was that the way that they originally used this is if you were showing up on a deployment, you were one of these four. You were either good to go, there might be a stressor that you're reacting to. It might be this is your third deployment and you're exhausted, or you may be in a state what they categorically considered ill, was more like the traditional PTSD, I think, that we would consider. But what it shows you, even in the paradigm where it first started, was that before you get to red, there's all these other iterations of stress impact where we could actually be looking at this and changing the dial. And I guess as we go through this conversation, we can think about public or rescue facing our subjects, and we can also start to think about each other. So what we did a couple of years ago, and I apologize, these slides, the format's gonna, I think, look kind of funny because of our technological challenges, but hopefully we can get the concept. What happened is last summer, I thought, man, this is really the language that I should be using. I was spending a lot of time treating really amazing men and women, firefighters and cops in the psychological ICU, because everyone was waiting to come see me until things were really bad. And I thought, this is really, disorder is not the right terminology for this. And if anyone can get hurt, anyone could get better. We needed to talk about this in a different way. And so we took that stress continuum, this one, and we calibrated it into law enforcement, fire, dispatch, and operations. And we have since calibrated, I just saw, and folks can look this up online, that the Climbers Grief Fund just calibrated this continuum for climbing on the Climber Grief Fund psychoeducation page. So we might start to see it in the language of rescue, and we have done this as well. The ski patrol I work with has also calibrated this for ski patrol. So on ski patrol, we might see something like in the ready that folks are excited, and wherever they are on the mountain, they're ready to go. By the time that they're operating in the orange, it might look more like, I don't want to work the lower mountain. I don't want to work with a rookie. Every time a call comes in, there's this big sigh of like, oh, I don't want to do this, right? And then red might look more like, actually being scared to ski. We see this, one of the robust conversations we've been having a lot in rescue is actually even how we consider the public wherever you might be on this continuum. So in the red, or excuse me, in the green, folks, that your pager might go off and you might think, sweet, I'm gonna get out of whatever I'm doing and get out there. In the orange, the pager might go off and you might think, and maybe actually I should say in the yellow, might come that moment where you've done all the work to be in search and rescue. You're already, you've got the gear, you've got the know-how, the pager goes off and you go, I'm actually not even doing anything and I don't wanna go. There's this sort of blah motivational exhaustion. So this has been helpful for us in rescue. We actually, with some of the rescue that I work with in national parks, we think about the green, amber, reds system where we actually, these are high angle teams who might come onto scene and evaluate their own risk based on where they are on the continuum. Why? Because we know that stress injuries occur in a state of stress. So if you're already in the red, when something goes down, you're depleted, you're exhausted, this is your third call, you don't feel like you have what it takes to do this, you're gonna get a lot more hurt by an incident than you might in the green. So this is what we mean that stress injuries occur in a state of stress. And we created a pocket card. Actually, there is a team that I work with on patrol that actually does the stress continuum every morning when they do their risk assessment. And the idea of, from a rescue standpoint is just shining a flashlight at the beginning of the day on where am I most likely to get hurt today? And if it's because I'm in the red, I'm gonna get impacted if we have a skier versus tree today. What are the things I can do to mitigate that in real time? So that's a little bit of a conversation overview on what's happening in operational rescue around changing the language so that we can, instead of having, knowing that someone's not doing well, and they're really not doing well and they're not coming out with us anymore and they're drinking a lot and we haven't seen them for a while, instead of putting the onus on them to wait and tell us and have to kind of like, well, let's just wait till it gets to PTSD and then we can address it. We're trying to have more conversation around, hey, I feel like I'm in the yellow. I could use some support here, or I just want someone to know. Here's what we know so far about how stress injuries form. And this was really kind of taking this back to public facing. Stress injuries form in a sense when there's a sense of overwhelm. So let's go back simply to that, let's go away from the sliding on ice. I heard a story this last week from some rescuers about someone who is doing swiftwater rescue who is heading for a strainer, who had a really, who really reacted to how scary that might have been. So if you're heading for a strainer on river left and you are swimming as hard as you can, and you finally just barely make it around the strainer, when you're swimming like that, when you're trying to overcome that and you see what a threat this is, again, there's going to be a flood of those like rush of fight or flight. When that happens, we start really paying attention. The part of our brain that codes these images for later starts taking pictures all over the place. Well, what happened in this, let's say in this context, for the person who just barely makes it around the strainer, keeps going and then gets down and can be a part of the rescue, they'll fire off this all clear signal, which basically is a way of the brain saying, whew, that didn't happen, it's over. And there'll be a rush of another kind of hormone that calms the body down, parasympathetic nervous system. Well, in situations where there's overwhelm and we cannot get out of it, these three things are present, which happens to be that, let's say we swim for the strainer, we can't quite make it around, the water's pushing us in that way. Hopefully this doesn't hit too close to home for anyone. We get pulled into the strainer and there's this moment of like, oh, this could be really bad. And nobody even knows where I am because they're all downriver looking for this person. And there's nothing else I can do to get myself out of it. In that moment when the response system is overwhelmed, there's isolation and a sense of helplessness, we adaptively fire off a different sort of, we're still responding to it, but there is a failure of this all clear signal. And even if somehow you get washed out the backside of it and you keep going downstream, the overwhelming response was capturing every single detail about that event because if you survive it, you have to spend the rest of your life trying to survive it again. And that's where we see all the marks. So when we look at post-traumatic stress disorder, hyperarousal, re-experiencing, intrusive thoughts, it's like a switch gets flipped, and all of a sudden your only job is now to survive instead of live. You're going to secrete a bunch of cortisol, and all those images and reminders are going to hide right below the waterline. And if they start to come up again, you're right there ready to survive it all over again. I would say that's stress injury formation in a nutshell. The problem is when you put all of your energy into surviving, you cannot put energy into things like innovating, learning, connecting, loving, creating. And this is why we might call this a disorder, because your life's purpose kind of gets hijacked by just surviving. So why does psychological first aid work then? How does it work? This is a paradigm that really came up in the middle 2000s after the first good innovation, right, which was critical incident stress support in the late 80s and 90s. After we had this onset of exposure type injuries, all of a sudden we had 1973 EMS Act. We had paramedics and ER folks like me and dispatchers and firefighters whose only job was to go from one stressful thing, exposure type after another, and take care of it. And there was a recognition in the early parts of this career that this is leaving a mark on people. We see, this sort of culture of like, let's go drink afterwards and being jaded and all this kind of stuff. So because of that early innovation being studied, hey, this works for some people, but not for other people in the early literature, there was I would say sort of a push to go back to the drawing board and say, what do we know based on the literature and expert guidance? And this was a global literature search with folks from Center for PTSD and National Child Traumatic Stress Network and the Department of Defense, and getting WHO involved and some of the big players. What do we know will mitigate traumatic stress in real time based on the literature? And they came out with these 5 elements, 5 recommendations of safety, calm, efficacy, connection, and hope. And candidly, this was actually first communicated to the, I would say, mass casualty setting of natural disaster and warfare, etc. But eventually, this has been sort of gone out to these 5 elements to combat and operational stress first aid, to the schools, and eventually it came to us in rescue through National FAWM firefighters and Patricia Watson's work, and then eventually it came to NOLS Wilderness Medicine, and now thankfully is not just for structural fire and patrol. We're seeing this in ski patrol and mountain rescue and technical ropes and avalanche as well. So it's unfortunate I can't sort of pause here and see what's landing for folks and get questions, but I'll tell you that I'm going to run through each one of these because this is, public facing, what we can do to come on scene. And actually, if someone has been incredibly impacted, maybe they just watched someone else in a slide, or maybe they just watched someone take a big fall climbing in front of them, or maybe you're responding to someone that's been on the side of a canyon overnight or for 2 days. These early evidence-guided interventions or tools actually do help. What the bottom line is, it helps to fire off the all clear signal. So instead of leaving that scene, your patient doesn't think that really the incident never ended, we put an end to the incident for them so they can start surviving and overcoming. So I'll tell you what they are, and I'll show you with I'll just give you an example at the end how it's being integrated into rescue. Safety, we actually use language to tell the brain you survived, that it's over. So we reduce stimuli from the scene that tells us that we are still in it. So we might actually say something like, and apologies for the S language, it could also be considered youth language. Use language that reflects safety. Now that you're safe, now that that's over, now that we've got you secured into the harness, now that you're packaged, now that you're on dry land or solid ground. because the brain at that point is only coding for things that tell us we made it. We're not doing complex calculations. It's literally like, is this good or bad? So providing accurate information to reduce anxiety, we have this amazing capacity to assume the worst has happened, right? As a matter of fact, if we know that one of our rescue members is involved in an avalanche, we will likely assume that the person swept, that they're dead, that something terrible has happened, because that's just how our brain's set up to survive. So if we leave people in that state for a long time, I think of one rescuer who told me that he spent all night looking for these kids, and through all the night he was picturing every corner he went around, he was waiting to see kids who he presumed were going to be hurt or dead. Although after he went off shift, the kids were found in the morning, his brain already wired for that eventuality and kind of made it true. So sometimes we actually give accurate advice like, yep, that is absolutely your partner, climbing partner, screaming over there. And what that means is he's got a good airway. He's feeling, we've got him secured. I love hearing people scream like that because I know that they've got enough oxygen and good blood flow to get that going. I'm going to get more information about what's next, instead of, I don't know who that is screaming. I don't know what's going on. So this is why we actually use and see press releases in law enforcement to allow people to turn, and these were one of the early recommendations, turn off the images on the computer of the tower falling or this happening again, and just get accurate facts that you need to know about where you need to be next. And so we're trying to do the same thing. Sometimes we'll give patients an operational update of what we know so far. Yes, both people in your party have been found with stable vital signs. That's all I know so far. Can be incredibly helpful. And then reducing the scene for them. Like this may be, as they often do in the parks, just driving an ambulance between the patient and the recovery effort, or just turning them around so they're not watching the recovery effort, or turning down the radio comm, or having someone else man that so that they're not trying to calm down at the same time you're getting input on the radio that things aren't going well for the other people involved in the party. So that's safety. Calm is the next one. Based on the literature, it started with things like this, that what they found in that early Hobfall article in 2007 was that men and women who had an elevated resting heart rate a week after whatever was the critical event were those most likely to go on to develop post-traumatic stress disorder. And there's a lot you could say about that, but the idea is that when we're physiologically still really aroused, it keeps sending a message to the brain that this is still happening. So we make a target when we can to get people to stop moving and actually calm down. We might feed back to them like, wow, your second set of vital signs looks really good. It's your heart rate's coming down, your respiratory rate's coming down. That's always a really good sign. We might use a stethoscope to keep having people do their lung sounds over and over again, because it's a great way, it's a great tool to get people to take deep breaths, even belly breaths, right? If I come up to someone who's having a hard time breathing or hyperventilating or in panic and I say, calm down. Okay, hopefully everyone's cringing because that one never ever works. But I say something like, okay, let's slow your breathing down, breathe with me. And they might say, it's not about my breathing. I want to know where my partner is, or I feel like I'm dying. If I then use a stethoscope and go, well, let's find out together. Deep breath in, hold it for just a minute. I'm going to move the bell of the stethoscope over here. Take another one, will you? And I'm actually engaging them in deep breathing. That can be another way to calm folks down. But at the heart of it is that we create calm by first calming ourselves down. So our earliest and first language before we learned English was learning how to read other people, right? The kids I work with in traumatic stress, the language, that language stays throughout their whole life, reading people's body language. You can't trick these kids. Is mom, dad mad? Is dad mad? What's going on? I know your words are saying everything's fine. So when we come on scene with a real sense of calm and we've got this, people really pick up on that and they really buy into it. It's really tremendous, the impact actually. So these are things to consider. Just coming on the scene, maybe your one takeaway from this webinar is, wow, it really matters to me how I present. I mean, you might have just gotten off the phone with your partner and you're mad at them about some purchase they made and you're coming on scene, but the patients don't know that. They're going to look at you and go, something's wrong, isn't it? You think I'm in trouble, don't you? So giving them our full attention. And if you can't, if you don't know how to get there, I mean, I know this sounds kind of cheeky, but like Mr. Rogers had it going on in the 70s, right? His cadence, how slow he talked, how well connected, that positive regard. Now we know that to be like really the foundations of how to work with kids in traumatic stress. I would maybe watch some Mr. Rogers videos. That's just me. Self-efficacy, this idea that I can be a part of my own rescue, actually combats the helplessness that we saw in stress injury formation. I'm on my own and nobody's coming and I can't get myself out of this is at the heart of most stories I hear of traumatic stress. So when you come on scene as a rescuer and say, hey, I want to know, can you help me with this? Can you hold the splint? Can you coil this rope? Tell me more about the trailhead. What we need you to do is tell me more about what they were wearing. Can you be a part of this rescue? It actually engages efficacy and it tells the brain, if this ever happens again, you can get yourself out of it. So we move away from the old paradigm where we might have said to folks, I don't know how this would have gone, but many years ago when I was a brand new rescuer in search and rescue, I loved putting on like the jacket and showing up. And it went something like, I'm the rescuer, you're the patient. Your job's to lay there. Matter of fact, so much is it your job, I'm going to strap you onto a backboard. And then I'm going to do everything for you, including like scratching your nose because you can't do any of it. We've moved away from that now. So again, one of the teams I'm working with, we've just had this conversation. Can we actually invite people onto our rescue team for the moment? Again, one of the teams I'm working with had a family member who was a paramedic of a person who they were doing CPR on, and that medic in his day job would have been doing everything. So they included him in problem solving and what else have we not thought of, and they actually had him help carry his family member's body down the trail. Now, can they fix it, this being the worst day of his life? No, not really. But to engage him in the last great act for his family member, that was really powerful. And I've seen other teams talk that through. Connection, as we know that connection is the single number one most efficacious or helpful intervention for mitigating traumatic stress. So the number one factor we know that will tell now, and this gets formulaic, how well people will do in overwhelming stress is really how their social connectedness. How much do they feel like other people are going to be there for them and can help them and support them? So we might leverage this by connecting people to their loved ones earlier on. We actually might just leverage it on scene by building an on-scene relationship and using their name a ton. I'll show you what that looks like in just a minute. This hope one is a little bit more intangible sometimes, but no less represented in the literature. We're representing specific positive facts that represent the future, basically, that the way it feels in this moment right now is not how it's always going to feel. And maintaining this personal sense that things can and will get better in the literature mitigates stress formation. So what this might mean is that teams, whether this is a public facing or team facing, well, I'll show you what this looks like a little bit, but we get capture from them that they know that we know how scary and hard this is. And then they look at our faces and they can tell that we still think they're going to make it out of this. So sometimes we build this up by just talking about how professional and amazing your fellow rescuers are. The things that are going with us. Hey, the good news is my favorite helicopter pilot is on. I mean, this guy used to fly in Vietnam. He's like unstoppable. He can get in and out of anywhere. He's so talented. It might be talking about things that are going for us on the scene. So just to close this up, I thought I would demonstrate just this rescue innovations teams that I work with have come up with. That language might be geared toward your own rescue. One of the guys I work with in Yosemite, Jim, I like how he says, I mean, they could be like 500, wrapping down 500 feet and they still got 1,000 to go. And he takes care of them, gets them all strapped in, might say, all right, well, the hard part's over. Now we just got to get down, right? That's over. Now all we have to do is, wrap down. We do this all the time, or lower you down. We love this part. So that's language they might use. In a climbing context, just giving evidence of like, hey, to climbers, it means a lot to hear bomber anchors and 11 mil rope. So you might use that terminology and leverage it. Having tangible evidence of survival, like having warm layers and hot chocolate. I mean, this is what the Red Cross has been doing for, a century. Wrap you up in a blanket and give you hot, a cup of something hot and connect you with your family members. Meet your physical needs. Calm might look something like really calming yourself down and checking in with each other. Like, all right, I'm going to slow things down here a little bit. I'm going to make sure I'm not freaking out before I head in there. And getting your patient to move, like we said, and stop physiologic arousal can be really helpful. And we have a lot of fun playing with the stethoscope there. You can do a lot. Yeah, the joke is, even if you don't know how to use it, a stethoscope can be a really great psychological first aid tool. Engagement, we had a conversation with Yosar this year about like, what would it look like to actually give them a yellow shirt and say, well, you're part of the rescue now. Here's what we're going to need you to do, and this is what we're going to do. But to really give them a sense of belonging as a part of the team. I think it's tremendous. And I know Yosar is one of the only paid volunteers mix search and rescues in the country, but when people see them come out and they're so cool and their yellow shirts and they're like world-class climbers, and when someone on Yosar says to them, no, we love being out here, they're like, they will all say something like, this has happened to every single one of us at one point, and we actually get paid to be out here. So you got us out to do something we love. And that can sometimes really decrease the shame barrier when they're like thinking, oh, Yosar is going to think I'm an idiot for getting stuck here or getting myself out here. And that does a lot to engage them as part of the team. We have a lot of fun thinking about getting folks to coil ropes and doing things that they always have done before. Hey, you know what we really need you to do? Coil this rope, will ya? Okay, could you flake it out one more time? Could you move it over here? And really getting them engaged. Connection, I think a great innovation is just the name tag, writing the patient's name on the name tag so that everyone who comes onto the scene actually says the person's name so they feel included. So it'd be like, I come on scene, hey, it's Laura. All right, John, you're gonna feel me moving you over. Next person comes on scene. Hey, John, Emily here. You're gonna feel me moving your feet or whatever. And so John hears John, John, John in sequence, which candidly is what we're all, that's like connects us to the people who named us and who love us. I put a picture of the SAR site on here. This is, we won't have time to get into innovations for rescue culture much, but this is a place where people gather after big things happen as a way to leverage connection on the team. And then finally, this last one for hope, we've conceptualized sort of a phase change briefing where we get enough capture to say to people, here's what we think we face. It is getting to be nightfall. There's a light drizzle. We're not sure the helicopter is going to be able to fly tonight. And I know you've got a pelvic fracture and you're cold. And here's what we got going for us. If any helicopter in the park can land right here, it's going to be the one who's working today. You've got stable vital signs. We have collectively, 87 years of rescue experience and some of the biggest names in the Valley here with us. And we just practiced on this last week so that folks who are listening can really hear, yeah, we know how dark and scary this is. And even the people who do this all the time, we have a lot of reasons to believe this is going to go well for you. So I think that what I'd like to do is kind of pause there. We certainly can talk about a little bit more, but to see if we have questions coming in. And we might think just a little bit as we're talking about supporting critical incident and near miss. And I'll put this slide up as we're kind of, I might pause here for questions to talk about how psychological first aid is now really moving into team-facing support. And the idea in National FAWM Firefighters was to teach it first to the team to do the people who they respond to. Because I think the adage, and I really believe in this, is like, well, if you have a firefighter who drops in with cardiac arrest on shift, why is everyone going to know what to do for that firefighter? It's because they've been practicing with the public probably 3 or 4 times that day or that shift. And now they know how to run their protocols. So in the same way, if we want to bring psychological first aid into team-facing culture, we might first start by practicing how to apply it to, the outward, sort of to the public that we respond to, and then we'll naturally sort of turn toward each other.
All right, that is a lot of very good information. It is very practical and applicable to a lot of search and rescue teams or just individuals in the rescue field. I would like to take this time to go ahead and type in your questions if you, excuse me, if you see the kind of the dashboard, that kind of skinny dashboard there where you can type in questions right there. Go ahead and type those in. I can see those questions. What I'll do is read out the questions and kind of organize them, and Laura can take them one by one. And we'll probably give a good 15 minutes or so for question and answer period. And just to let you know, this webinar has been recorded and will be available through MRA as well as PMI website, which is pmirope.com. So we keep all our webinars at that location. So and Laura, if you have any resources that you want to provide, any contact information or anything like that, we can kind of bring that up at the very end after we wrap up the questions.
Sounds good.
Okay. All right, go ahead and send your questions to us. I do have one question. The first question here is, what is the evidence base for PSA?
Right, so if you look back through the early literature, I think the evidence base for PFA might actually start with the evidence around critical incident stress debriefing that was at first had not been studied at all, but by the time we saw the 2002 Lancet journal on review of outcoming implications for and when I say CIC, I mean a very traditional Mitchell model gathering. There was then, and again, I want to really stress, this was the first early innovation. I think a lot of us have had really good experiences gathering after critical events. We just found out it wasn't working for everyone. And so in 2007, this gathering that I spoke of is a Hobfall et al. 2007 article, I think it might be called The 5 Elements of Psychological First Aid. I think it's a really sentinel article, and we've posted it on the Responder Alliance website for reference to folks. And so after that, I think sort of came a flood of both National Child Traumatic Stress Network, Center for PTSD, and SAMHSA, all implementing aspects of this, again, for school base and military base. But I would say that if you're looking to sort of follow the thread, the first early threads came through Hobfall, and if you follow Hobfall's work or Patricia Watson's work through the course, these are just a few names, you'll see more. It is highly cited with the research and evidence that they used to first establish these 5 elements.
Okay, great. Let's move on to the next question here is, how do you handle a hectic crowd near a rescue operation?
Well, I think awareness then choice first, right? Like being aware that the crowd is all hanging back with a ton of exposure and very little efficacy, meaning they feel helpless. They're watching this happen. They don't know what to do. So, my preference would be to give them accurate information and then give them a job and connect them to each other. And sometimes sometimes we are literally up against can the 5 of you go gather moss? We might need it later. We're going to need a lineup of stones pointing as an arrow to the ambulance when it comes. I mean, whatever it is, but to actually make them feel part of the rescue and and sharing. I mean, you can apply PFA to that crowd, right? You think about calmly responding about what's going on, connecting with them to see how scared or shaken up they are, giving them a job for efficacy, and then letting them know how talented the rescuers are, and that they've trained for this. Making sure and fundamentally that they are safe or they feel safe. We can just apply this toward a crowd.
Okay. This one, the next question is, how do you address the culture of rescuers feeling like they have to be strong and can't admit to feeling stress? Second part is, what's the best way to get someone to talk that maybe feels ashamed that they are stressed about something that they think they should be over?
Let me see if I can get at both of these, or you might have to circle me back for part two.
Okay.
I think that what's important, I work with high reliability teams across the board, right? All hazards, which means firefighters and cops and SWAT teams, as well as high angle rescuers and, I think it generalized badasses. And I think it still is true, though, that we have a human machine that needs to be cared for. And so I think that the language around this is really helpful. Up until now in rescue culture, we have left this to be what happened to you sort of scenario. Like, oh, is this getting to you? Oh, you should do something about that. We're really, and this is why I put this definition up, we really should just look at this more, that stress injuries are common, predictable exposure injuries that I've written this again just to stress this, are predictable and reversible and treatable when recognized. So my opinion is that we should be starting in prospectus and trainee classwork to say, yes, you could fall off the side of something. Yes, you could hurt your back. Yes, this could happen to you, head injury. But the most predictable injury type that you will experience across your rescue career is stress injury. And some people are impacted early and some people are impacted late. But the language tells us that even, we have to be people who are willing to cross the red line even to do the things we're doing, right? Some people would have an opinion about what that means about us, but it means that we're going to have a very high threshold for when we feel scared or talk about feeling scared, but we still get to feel scared. It's not, I just had a conversation, we were addressing a local SWAT team that had to do something. I said, probably half of their hands were shaking because they're human beings. Just because you're doing hard things doesn't mean it's not impacting you. And so I think there is a tremendous shame barrier that goes sometimes with people feeling this. And so what I like about the stress continuum and bringing it into rescue language is it just shows that everybody has a stress continuum, and everyone will, what we'll do, what we did with YOSAR in the beginning, what we do with other rescue teams is actually calibrating that rescue, that continuum to say, what do you do in green? What do you look like in yellow? What do you look like in orange? Or what do you look like in red? And if you don't know, ask your partner. They could probably fill it in to the T for you. But we all have a breaking point. And so if you're stress impacted by that, that's probably more about being a human being. Stress, nobody's meant to go in a building where there's a carbon monoxide leak and without some way to mitigate that and protect against it. And that's what we're talking about here. So that's where I think that the language matters so much. And these are some of the new terminology that we're seeing used. What's the second part of that question?
Okay.
Did we get to it?
Yeah, well, the question is, what's the best way to get someone to talk that maybe feels ashamed that they are stressed about something that they think they should be over?
Maybe, I would see that one of the things that helps a lot is leading with vulnerability. No one wants to be the only person who's impacted by something. So maybe the person who's worried might reach out to them first and share how they were impacted by a similar event. We have gotten a lot of traction just taking that stress continuum to teams and describing the behaviors that people do when they're overwhelmed. And then people surprisingly are willing to talk because they're like, wait, that's me. I'm in the orange. They're actually talking about me. And then we had some opportunity to get that done.
Do you find, do you have resources like for SAR teams to go outside of their team to get that help or to address those issues so it's maybe not so public within the team, but then they're addressing it on their own?
Sure, I would say that the early adopters in the SAR culture on this stuff are the ones who are making a bit of a pipeline. We often are doing embedded resilience training on teams now. So there's like a small team of folks who are like keeping an eye out for people's exposure. Maybe they're following up after events. And that team is often tasked with like, can we use EAP? Is there a local therapist who understands what we do that we could go to? Who are the other resources? Is it something through the sheriff's department that we can trickle down? If that's not in place and easily available on your rescue team, this would be a wonderful place to start. Because as much as we talk about this being important, if we say, if you find out you're in the red and there's nowhere to go, we have an incentive for people not to identify that they're struggling. So we're seeing that through I know in Colorado, there's pursuit of this through the local legislature. In some areas, it's creating a grant or a trust. In some areas, there's a foundation that supports it. But it can be a challenge. And so I think this is a question I would like for us to be sharing with new perspectives and trainee. Like, if you get hurt in this way, what do you do about it? It should be a 1-2 punch, but I don't think all teams are there yet.
Okay. Next question. How would you deal with anticipated stress in new SAR members before their first call out?
Meaning if they were feeling really anxious about the first time they get called out?
Yeah, I think probably just being new, learning new systems, just, trying to deal with the stress of, the trauma and that kind of thing. I guess is just touching on the new SAR members.
Yeah, I think new SAR members have a tremendous sense of that people expect something of them. They have to prove themselves. They're not 100% sure that they know what they're doing, but they may not always have a mechanism to say that because they're afraid people won't think they're competent. So I think that mentoring into those roles, I think it'd be innovative on a SAR to say your first 3 rescues, you're buddied up with a senior person, and we expect you to have a ton of questions. We like that. We think that's healthy. So ask them. We don't expect you to know everything from the get-go. And I think that normalizing stress in this whole conversation is really important. I mean, stress has kept us alive for millennia. It makes us pay attention. We just don't want to clip over into overwhelm. So to let them know, I mean, optimal performance happens somewhere along the line when you feel stress. A lot of us feel, and stress may not be the word, but that anticipation or sort of, on edge or ready for the next thing. But I think talking about stress injuries so that people know when they clipped over. I think after the first few rescues, there's a lot more effort now, especially if your first rescue ends up being some terrible suicide recovery, that someone who has leadership goes, hey, that wasn't normal. We don't do that all the time. That was even hard for me, just so you know. Because this happens all the time where someone in their first few rescues gets pulled into something horrific. And then they go, okay, is this what I actually signed up for? Everybody else seems to feel like this is just fine and I'm not okay. And what we really need is, like we just talked about, normalizing by saying, wow, I've been at this for 15 years and that one stuck with me. That was really hard. This is what I usually do when I feel overwhelmed after a rescue, and sort of modeling that is super important.
Okay, we have a scenario here, and I think it's definitely on topic, and so I'm just going to kind of read through this real quick. Our team had a recovery where a mother fell from a cliff. The father and 2 small children were present and witnessed the incident. Our team packaged and transported the body. The family hiked down with other team members with us. How would you manage a situation that children directly experience the death or serious injury of a parent?
And I think we're at time, so this is a really complex question and maybe simple in some ways. Let me say first that that is an incredibly high impact situation. So this is one that I would hope a team really puts a tremendous amount of support. What we know, and I've just flashed this up here, what I tend to see, and I have seen over the last few years, is that when there's family contact with the grieving family, it really needs to be included as mechanism of injury for stress injury formation. So maybe there's a personal connection and kids are involved. And this, I just put this up because we literally in some rescues will use a checkbox to tell us this meets, it's like mechanism of injury for spine. If those remember back in the spine days of wilderness medicine, we go, oh, it's a fall greater than your body height. It's a head injury, check, check, check. This is spinal precautions. I think a situation like this should trigger a stress protocol or spinal precautions or follow up, or I mean like emotional support precautions, because you know, it was overwhelming, I'm sure, for the rescuers to say we've never been in the middle of a family, like showed up in the middle of a family death before. We already know that the kids are so injured and impacted, because who wouldn't be? And then how much efficacy was there in terms of what happened with the family? And so, although this is a very specific situation, I think that some of the things that really help are gathering together to name how impactful this was. Sometimes it can be helpful later on to find out that although the kids were incredibly impacted, they are doing well, maybe to follow even their story a year later, because we leave that story thinking they're ruined forever. Life can never be okay for them. And so sometimes this is where follow-up with the story can be really helpful. But I would hope in a situation like that there was care on the team. Now remember, just to maybe end here, that if you work with the continuum, this is why we do, if you know what your baseline is and how to return to it, if you know that you usually hang out and rescue at a nice lime green, and after that family event, you've been hanging out in the orange, I still am having nightmares, I'm not myself, I'm short fused, the team doesn't, we see stress injuries occur on teams. The whole team is not functioning well together anymore. There's like this grief that got stuck being that close to that incident. I guess I would say we don't have time in this venue to talk about the best practice how to, but I will say that psychological first aid and on the team, right? Gathering together, reestablishing that was over, connecting with people afterwards, going back to what, even though it was a terrible situation, this is what we did well for that family on the worst day of their life, and hope in terms of the kids' stories. So I don't know that I could do that justice. I know we're wrapping up, but hopefully that gets at a little bit of what the questioner was asking.
That is terrible situation and difficult to deal with. I think a lot of the other questions were answered in your presentation. So I want to combine a couple of last questions for one more question, if you don't mind.
Sure, I think I have one time for one more.
You time for one more, okay. What does your own self-care look like, and can you speak to that?
This is me personally, self-care, someone like to know?
Yes, and there somebody else asked about how does this apply to one's personal life. So I guess that's the question,
Yeah,
is like, how do you really apply it to yourself?
Well, what we have found working with this continuum over time, it's really helpful sometimes to spend time on what does green look like? What, if stress injuries occur in a state of stress, then what does it mean to be emotionally and physically ready? It usually means, trauma doesn't get integrated on its own. And my clinic, I don't have a magic wand to make trauma go away. Where trauma gets cared for and integrated is in family systems, in connection with other people, when you have enough space to integrate it. And when there's room for that kind of complexity, you don't feel so overwhelmed. So in a lot of urban, structural, I just worked with a peer support team yesterday. We spent a lot of time on what are your personal kind of quote unquote green choices. I mean, if you picture someone who's quote unquote green on a team, they're still engaged after 20 years, they have a sense of vitality and hope, they have a life outside the uniform. If you take them out to lunch, you're gonna find that they have practices that sustain them in green. It may be a meditation practice, it may be a spiritual practice, it may be a connection practice. It may be a sleep practice. And so if you know what those things are, then leveraging those is really, I'm not sure that self-care is a term that resonates with me, but I can tell you that if I bring intention, and I think the worksheet for these green choices are on the Responder Alliance website, and we actually did a module on this, and this might be the best way to talk about this for the MRA with Nick Constantine, Seattle Mountain Rescue, about green choices and moving toward green. But it really does, for me, it actually means saying no to things so I have enough space for integration and for there to be enough margin in my life that if something hard or sad comes in, I can make room for it so he can land in me. I think so much of the trouble for us as busy rescuers is we just think, I got to think about that later. I got to get to that later. And we have so few spaces in our life to really take things in and make a story. It means no matter how busy I am, being committed to the connection with the people who know me and love me and having practices that are around health. Like when I stop running or climbing and when I stop sleeping, by definition, I know that I'm moving toward the orange. And so I think it's really, I think the way you trend toward green is you claw your way there in a lot of ways. But the good thing is that the farther into green you get, the more it starts to recharge your batteries, and it feels good to be there, and you have more of a sense of both mission and vitality, but actually motivation and joy to do the things that sustain you and healthy. The farther into the red you get, the harder it feels like to get yourself out without other people's support. I hope that answered that, and maybe I can leave it with that there are some resources. We actually did this with the MRA, this 3-part series. If folks want to dive deeper or talk about how to do this on their teams, we recently did a 4th on debriefing and what helps, and so hopefully we'll see some of that coming out soon.
Okay, great. Any final comments to close things up?
No, I just think if folks are, listening today and are looking for one take-home thing to do, I would say that because the literature takes us there, that to really shine a flashlight on your connectedness. The one thing that this, as I said, I'll say it again, the single most effective thing that we know that will buoy you or be your external immune system in difficult times is how connected you are right now. So if there's not 1 or 2 people on the team that you have like a little text stream going who check in with you after, start that. If there are people in your life, if most of the people in your life have no idea what you do in rescue, invite them in. We want the families and significant others to be in on this technology too, because of how, I think all of us, rather than thinking I can only do this for another 2 years and then that's it, I'm depleted, I would like for someone to, in another 20 years, I've been at this a long time, to have to drag me into retirement because they say, I can't hear you anymore and nobody understands you anymore, but you're so passionate about it, we don't want you to stop. So follow that mission battery to connection, and I think that's a good place to start for both the team and the individual.
Great. Thank you so much. This is very, very good information. And like I said, we have recorded this webinar. You can find it at pmirope.com. And if you look, there's like a Facebook and a YouTube, Instagram icons at the top of the page. If you push the YouTube icon, it'll take you straight to this webinar, and you'll be able to find our past webinars. Also, under Use Your Gear, there's a drop-down menu that says videos and webinars that you can look up other webinars as well that we've done. And I would like to thank Laura McGladrey for being here. Thank you very much. Keep an eye out for more PMI and MRA technical webinar series webinars that will be coming up. We're doing quite a few of these, and like I said, you can view those on the PMI YouTube channel if you'd like, and we also give these to MRA to post as well. So thank you for attending. Keep an eye out for future webinars, and thank you to Laura McGladrey.
Thanks for having me.